Hello everyone, my name is Osama and today I'm going to talk about cardiac failure, which is P14. So, first let's define what cardiac failure is. Cardiac failure is anything that causes the heart to not pump enough blood to accommodate the body's needs. And these are the following causes. They can be anything, absolutely anything, that causes the heart to not pump enough blood to accommodate the body's needs. These are some examples. For example, myocardial infarction when there is coronary insufficiency to the heart muscle and there's damaged heart valves. Vitamin B deficiency, which is a disease called the wet beriberi. Increased pressure on the heart, which is fluid accumulation around the heart, not allowing the heart to contract and relax appropriately, which is also known as cardiac tamponade, and primary disease of the myocardium, which is also known as cardiomyopathy. In this case, there's basically there's any disease that has anything to do with the heart muscle will probably cause heart failure. Okay, so for the sake of simplicity, we're gonna discuss myocardial infarction. Now, the immediate effects of cardiac failure are two: the reduced cardiac output and increased venous pressure, mean systemic ring pressure. Why? Because the heart cannot pump. Why reduced cardiac output? Because the heart can't pump enough blood, so that will reduce the cardiac output. And increased venous pressure, since the heart is not pumping the blood will back up into the veins, increasing the venous pressure. And now let's discuss this graph. Now at point A is the normal cardiac output. Now this graph only shows the cardiac output, okay? Point A, this is the normal cardiac output. If you notice, there's cardiac reserve. This is the maximum cardiac output. This is the cardiac output at rest. So if this person decides to exercise, they can exercise and their body can accommodate the increased need for oxygen, since there's so much cardiac reserve. Now, if this person goes into acute heart failure, they will end up at point B. Now at point B, you can see there's low cardiac output, lower than the 5 liters per minute which are needed at rest, and there's also high right atrial pressure. Okay, now if you see this, this is always acute heart failure. Okay, so this change from A to B shows that there's lower cardiac output and high right atrial pressure. Right atrial, should have put right atrial pressure here. Okay, so the body will try to compensate for this heart failure. Now the first reflex that's going to take place is sympathetic reflex. Okay, so it will take place immediately, and this will cause the circulatory dynamic point to change from B to C. Now it increases the cardiac output a bit, but it's not enough. So another reflex will take place where there will be more water retention by the kidneys. Now this will cause it to increase to point D. Now at this point, if you notice, we're back to the same cardiac output of 5 liters per minute at rest. But this person at point D cannot exercise the same way person A does. Why? Because he has no cardiac reserve. If you notice, this is the maximum cardiac output he can produce. He cannot produce a greater cardiac output, so he has no tolerance to exercise. Okay, so the four reflexes that work in the sympathetic response are the baroreceptor reflex. They will sense the low blood pressure. Chemoreceptor reflex will sense the high CO2 or acidity in the blood. CNS ischemic response will sense the low blood pressure in the central nervous system. And at the damaged myocardium, there will be reflexes that will also cause the sympathetic response. Okay, now there's a dark side to the sympathetic response. If there is large damage to the ventricular myocardium, this will worsen the condition. Why? Because the pump is too weak to handle that much stress. You're asking a failing pump to pump even more blood. So what will happen is it's gonna run out of oxygen faster, and it will get even more damaged. Okay, so it's not always good. Now, why do you want to retain more water by the kidneys? Like we said, the change from point C to point D is by more water retention done by the kidneys. We want to do that to increase the mesosystemic venous pressure, mesosystemic filling pressure, my bad, and the vein or slash the venous pressure. They're the same thing. Okay, so why do you want that? We want to distend the veins, and we want more blood to end up being in the heart so we can pump it. Okay, and we also want to distend the veins, which means we want to increase the volume of blood in the veins, and so that will reduce venous resistance and facilitate blood flow to the heart. Now, there's a dark side to long-term water retention too. Since you're retaining more fluid and you increasing the fluid that goes back, increasing the venous return, you're giving more workload to the damaged heart. Like we said, the heart is already damaged, it's a failing pump, and you're giving it more work. And you can overstretch the heart muscle. When you overstretch the heart muscle, that's not optimal for the heart muscle to pump blood, okay? And it may cause pulmonary edema, we'll dive into that later, due to the failure of the left ventricle. And it might cause extensive systemic edema, and we'll also dive into that later. However, if a person has a myocardial infarction, they can have a recovery phase where collateral blood supply will go towards the area around the affected area, the infarcted area. So there's areas around the infarcted area, they have less blood supply, but they're not as ischemic as this area right here. So collateral blood supply, new blood vessels will form towards this area to supply it and make it function again, so it can pump even more blood. And the unaffected part of the ventricles, they will undergo hypertrophy, which means the muscle will become bigger and stronger, and this is a compensatory mechanism so the heart can pump blood even though some of the muscle is dead. Okay, now we dive into compensated heart failure. Now what we saw, the mechanism we saw is called, it ends up with a condition called compensated heart failure. Now in compensated heart failure, if you compare A to D, you have a normal cardiac output but a high right atrial pressure. And if you notice, there's no cardiac reserve unlike at point A. Now, when it comes decompensated heart failure, the same reflexes that show up in compensated heart failure also take place in decompensated heart failure. However, the damage to the myocardium is too big, so we cannot restore the same normal cardiac output. Okay? The right atrial pressure is getting higher due to more venous blood damming because of more fluid retention and less pumping activity by the heart. Now, the dark side of the reflexes that should restore the cardiac output will start taking place. Remember the dark side of the reflexes that we talked about, the water retention and sympathetic response. Now they'll start taking place, and they will reduce the cardiac output even more. Now we can treat decompensated heart failure. It doesn't always work, but we can treat it. We can try. Okay. Digitalis, it's a cardiotonic drug. It inhibits the sodium potassium pump. Now, how does it work? How does it affect the heart? Okay, by inhibiting the sodium potassium pump, the sodium potassium pump is supposed to pump sodium out of the cells. If you inhibit it, more sodium will accumulate inside the cell, and what's gonna happen is this will reduce the activity of what we call the sodium calcium exchanger. The sodium calcium exchanger is supposed to bring sodium in. Now it's gonna see that there's lots of sodium in, so why would it work? So and it's supposed to kick calcium out. If it doesn't pump sodium in, it won't pump calcium out, so calcium will also accumulate inside the cell. Now we need calcium for contraction, so calcium inside the cell will increase the contractility of the heart, and sodium inside the cell will cause the membrane potential to be more positive, so so the heart itself will be more excitable. Now three more treatments for decompensated heart failure is diuretics. Diuretics increase fluid excretion through the kidneys. We want to decrease the venous pressure so the heart can be more comfortable. And we can remove the clot if it's a clot, surgically remove it. Or we can infuse streptokinase or tissue plasminogen activator to dissolve the clot. These two drugs will dissolve the clot. Now note, if the heart is in compensated heart failure and it faces a new stress, the compensatory mechanisms that take place, the sympathetic response and the water retention, they will fail. So that will lead to decompensated heart failure because they can barely keep the normal cardiac output at rest. If you add a new stress, they will fail. Now this is a normal heart. These are cartoons that kind of show what happens. Okay, now this is the normal venous return, and this is the normal pumping activity of the heart. In a failing heart, you'll have accumulation of venous blood. There will be greater venous return, but the pump itself cannot pump as much blood. Okay, now this is known as low output cardiac failure, or also known as cardiogenic shock, where the heart receives so much blood but it can't pump enough. Now, as an example, like we said, compensated heart failure, if it faces a new stress, that will lead to decompensated heart failure. Now these are two examples. If you increase the preload too much, the heart literally cannot pump the blood. So if you give it more work, it won't be able to do that much, that greater work. And this is another example that's increasing preload, and this is another example of increasing afterload. If you can, for example, if there's stenosis or constriction in the vessels, the heart cannot pump through the small stenosed valve, so it basically cannot. The pumping activity will be even less. Okay, so these are two examples of how a compensated heart failure can turn into decompensated heart failure. Now, pulmonary edema, we talked about before. When it comes to unilateral failure, if the left ventricle fails alone, the blood will accumulate in the left atrium and back into the pulmonary veins and back into the pulmonary capillaries. And if you remember from the stalling forces, the capillary hydrostatic pressure will increase specifically in the lung. Now we have plasma colloid pressure. It's around 28 millimeters of mercury. If the capillary hydrostatic pressure exceeds this value, since the plasma colloid pressure is for absorption, and the capillary hydrostatic pressure is for filtration. If hydrostatic pressure exceeds the plasma colloid pressure, there will be more filtration, more fluid will move out of the capillaries and into the lung, causing pulmonary edema. If you see here, more fluid enters the lung, and it will cause death really quickly, within 20 to 30 minutes, immediately after acute heart failure. So if a patient has acute heart failure, in the left ventricle specifically, they might drown in their own fluids within half an hour. So in acute heart failure, what happens is mean aortic pressure drops, right atrial pressure increases, and since mean aortic pressure drops, this will cause the capillary pressure to drop too, from 17 to 13. At some point, they will all converge at 13 millimeters of mercury, this specific pressure. Now, this happens later into heart failure. So, for this reason, acute heart failure does not immediately cause peripheral edema. Even if the patient reaches this point, there's so many factors in place. Like I said, there's the other three stalling forces, not just the capillary hydrostatic pressure. And there's also the lymphatic system. So there are many factors in place. So that's why not all heart failure patients experience edema. Now, this atrial natriuretic peptide. It's produced when there's increased right atrial pressure. Now this compound AMP, it will increase sodium and water excretion through the kidneys. Why does it do that? It protects the heart from overstretching. If you increase the venous return, this will cause the heart to overstretch, and you won't have optimal cardiac pumping. Okay, and this is one of the extreme symptoms of decompensated heart failure, and AMP prevents this symptom. Okay, now let's talk about the concept of cardiac reserve. Okay, so diagnosis of low cardiac reserve is confirmed with an exercise test. Now, why do we convert to the exercise test? Because in exercise, we're increasing the stress on the heart. If the heart cannot keep up with that stress, we can say that this patient has low cardiac reserve. Now, what are the signs we want to look for? It's immediate and extreme shortness of breath, extreme muscle fatigue, and excessive increase in heart rate. Now, these are examples of diseases. Of course, an athlete will have a higher cardiac reserve because their heart is trained to have that. But the other diseases, they will have low cardiac reserve. Now, let's talk about decompensated heart failure. Now, the graph I showed earlier doesn't have the venous return. Now, this one has it. Okay, so at point A, this is normal. Okay, we have we have the normal right atrial pressure, which is usually zero, around zero. Okay, and we have a cardiac reserve, so this person can tolerate exercise. Okay, but when he moves into acute heart failure, he moves to point B. Okay, now in point B, he has higher right atrial pressure and a very low venous return. Now the sympathetic response will increase the venous return, which will cause him to move to this point, increasing the cardiac output by a bit. Okay, and like we said, water retention will cause him to move to point D, and at point D, he has a much higher right atrial pressure, and he met the 5 liters per minute, but he has no tolerance to exercise. He has no cardiac reserve. Now, when it comes to untreated decompensated heart failure, like we said, we can treat it with digitalis, for example. If we don't treat it, you can see that it will deteriorate. It will become worse day by day if you don't treat it. Why? Because the reflexes will take a vicious cycle, and the dark side of these reflexes will happen, which will cause the heart to deteriorate even more. Okay, and it never meets the 5 liters per minute. Now, how do we compensate a decompensated heart? Now, in this example, we use digitalis. Like the black line here represents the same line we saw here, but the red line represents the heart, the decompensated heart that is treated with digitalis. Okay, so in this example, it actually exceeds the normal 5 liters per minute, so we met it, and we made a decompensated heart to move into compensated heart failure. It's still barely above the required cardiac output, and this person still also has a low cardiac reserve since their heart is barely meeting the cardiac output at rest, so they have no tolerance for exercise. Now, let's move into a different example. We've been talking about low output heart failure. Now, let's talk about high output heart failure. It occurs as a result of these two conditions. There can be more conditions, but these are the most common. AV fistula, which is a arteriovenous shunt, which is basically we connect an artery to a vein. Now, what will happen in this case? It will bypass the arterioles, the site where there is vasoconstriction, the site of resistance, vessel resistance. Since there is no resistance, you will increase the pressure, the venous pressure, since the artery is pumping blood into the high pressure in the arteries, pumping blood at a high pressure in the venous system. This will increase the venous pressure, increasing venous return, and increasing venous return will increase cardiac output. Now remember this very well. When you increase the venous return, the heart has to increase the cardiac output. Why? Because we can't have blood accumulating in the heart. Okay? And in beriberi, you'll have less ATP production. This is vitamin B deficiency. It will cause less ATP production, which will cause less vasoconstriction, less resistance, total peripheral resistance. So this will cause higher venous pressure and will cause higher venous return. Okay? Like we said, they will increase the venous return and the heart must match it. So it increases the cardiac output. Now the heart will have a higher cardiac output at rest and no cardiac reserve. If you notice here, the cardiac output at rest is higher than 5, the normal here at point A. Okay? So for this reason, the person will not have a cardiac reserve. This is the example of the AV fistula, and this is the example of beriberi heart disease. Okay? The patient has no cardiac reserve and they have high right atrial pressure. And this is an example of high output heart failure. The heart has a high cardiac output, but it's failing at the same time because it has no cardiac reserve. Now, to end this lecture, I'll ask a question. What may occur as a result of left-sided heart failure? Feel free to pause the video and think about the answer. Now, the right answer is A, pulmonary edema. We go back to the slide. When we have left ventricle failure, there will be more blood backing up into the left atrium, into the pulmonary veins, and into the pulmonary capillaries, which will increase the capillary hydrostatic pressure in the lung, and it will cause pulmonary edema. And thank you, everyone. Good luck with your studies.